If you or someone you love has intense anxiety around food, maybe food preparation, mealtime, you might be wondering, is this ARFID? Is this an eating disorder? Or is this OCD? Or maybe an entirely different condition? My name is Kimberly Quinlan. I'm an anxiety specialist, and today I'm going to be focusing on breaking apart these different presentations might appear to look the same, but in fact, these are completely different conditions and that require different specialized treatment so that you can get the recovery and the outcomes that you want. Thank you so much for being here. Your Anxiety Toolkit, we're here to bring you all the virtual hugs and effective strategies and science-based tools so that you can get better faster. That's what we're all about over here at Your Anxiety Toolkit. So let's get to the bottom of what is OCD, what is ARFID, is it maybe something completely different? We're going to pull apart, we're going to dissect this and go through it together so that you know that you can move forward and get the correct treatment that you deserve. So let's go. So oftentimes clients will present in our office with these symptoms of anxiety around food, lots of preparation, a lot of rumination about food, maybe a lot of checking of the food item. There might be a lot of distress around eating. There might be massive emotional dysregulation around mealtime. These are all things that a lot of people are struggling with. However, what we want to do before we immediately just jump in and try to target specific symptoms and manage different avoidant behaviors is we want to understand what is actually going on. What is the underlying fear of these behaviors? And when we identify those specific underlying fears or what the function of those behaviors are, we can then identify the correct diagnosis, the correct treatment plan, and we can address any nuances that, believe it or not, are incredibly important when deciding on a treatment modality for these symptoms that are presenting. Like I said before, the same symptoms could be a OCD, it could be ARFID, it could be an eating disorder. Most of the time, we will actually hear from clients who said they got put in eating disorder treatment with a bunch of, people, maybe young females, if that is the most common, generalized population, when really they had an OCD diagnosis. Or they're being treated for OCD when they maybe have ARFID and they've been misdiagnosed in that way. Maybe there's a combination of these two, and we need to identify the function of each behavior so that we can find the specific treatment for that behavior, whatever it may be, a compulsion, maybe a safety behavior, and make sure that we're being as specialized and as customized as we can. So today we're going to talk about how to differentiate between them and also look at a few of the different methods of treating these conditions. Okay, so as a clinician, I'm always going to focus first on doing a thorough assessment. Now, what would that assessment involve? Well, first we want to understand what particular behaviors are going on. Often by the time people come to us, they're very malnourished. Maybe their doctor or a nurse has referred them, or their general practitioner, saying, this person has dropped weight or has maintained a low weight for a very long time, and I think it's time for you to get some mental health help. Now, by the time they come to us, they may already have done a Google, search, and they feel that they resonate with a condition or a certain anxiety condition or mental health condition. That would be ideal. But if not, we're first going to look at what specifically is going on. Now, common symptoms for all three of these, OCD, ARFID, and an eating disorder, will involve, again, a significant reduction in food or food groups, a lot of rumination around food, a lot of avoidance of food, avoidance of mealtime, a lot of reassurance seeking around certain foods, a lot of checking of food behaviors, counting of calories and counting of certain parts of the food. And again, just a general overwhelming degree of distress. But what we want to do then is, once we get a thorough understanding of the safety behaviors that are being done, we want to ask the question, what purpose do these behaviors serve? What is the underlying fear or the underlying concern that's causing you to engage in these behaviors? Now, let's first talk about OCD. When it comes to having OCD or food-related obsessions, a lot of the time the person is engaging in these behaviors because of specific obsessions that they may have. A really common example of this might be contamination. They might have contamination obsessions, which means they're avoiding foods, checking foods, examining foods, having a lot of distress in fear that that food may have some kind of poison in it. Maybe it may cause them to get sick. Maybe they're afraid of the germs or the mold that might be associated with that food. Maybe they have a fear that that food is out of date, and that they may get a illness of some type. Maybe they'll throw up and they don't want to. That would be very common for someone with contamination-related obsessions. Now, there are other people who have more symmetry obsessions related to their food. They want to know that their food is aligned, symmetrical, numbers. Maybe they're good numbers, not good numbers, and so forth. Maybe there is some just right obsessions involved in that they feel like the food has to feel right or smell right or taste right. Maybe it has to look right. Maybe they can't touch and it doesn't feel right for them to touch. Maybe it doesn't feel right for them to be cooked together. It could be many reasons when it comes down to just right obsessions. Other obsessions related to OCD might be scrupulous or moral obsessions, such as if I eat meat, I'm a bad person, or if I eat this certain food when I have this certain thought, that would make me a bad person. Or again, maybe it's a religious obsession. If I have a bad thought about God while I swallow this item, well, then I may or may not go to hell. Again, causing them to avoid food in fear that they will have that intrusive thought. Often people with health-related obsessions may be afraid that the food may set off an allergic reaction. Maybe they're afraid of going into anaphylactic shock. Maybe they're afraid that if they don't cook the food correctly, they don't examine the food correctly, that they may cause harm or illness to other people, therefore avoiding the food, ruminating about the food, or having significant impaired distress related to mealtime. Now, other examples of OCD could be really anything. Sometimes OCD can attack things in ways that we would not have even thought of. These are common ways in which OCD can target food and food routines and cause someone to become malnourished or have a lot of rituals around food. But the key point here to know is that there is a different primary fear related to their food-related compulsions. The food compulsions may be, as we've mentioned, counting, a lot of preparation, avoiding food, reassurance seeking, maybe needing to take small bites, big bites, certain amount of bites, certain amount of chewing. It's very ritualized. And again, there's a lot of avoidance involved. Okay, so now we want to look at what is ARFID. Now, ARFID is an acronym that stands for Avoided Restrictive Food Intake Disorder. It's actually its own diagnosis and it's under the umbrella of an eating disorder. But again, so often folks with ARFID get misdiagnosed with people who assume that they're avoiding food or restricting food, or they're having a lot of distress around food because of their fear of gaining weight or their fears and concerns around body size and shape. That is very common for folks with eating disorders, and even though ARFID is under the category of an eating disorder, it doesn't have to have anything to do with the person's perceived body shape, weight, or any body concerns. For folks with ARFID, they tend to be more concerned about the sensory experience of the food. The reason they avoid foods, the reason they have all these ritualized behaviors around food is because they have a high level of distress and fear of what will happen when they eat that food item. Maybe they will have disgust. Maybe they don't like the texture. Maybe they don't like the smell. Maybe they don't like having things touch because they have this strong disgust reaction when they do. The thing to remember for people with ARFID is they aren't just afraid of food, they're often afraid of the consequences of eating. And often, this is not fear that's irrational. Oftentimes, they actually have a very strong disgust reaction within their body. That idea of eating is gross, it's repulsive. They may have no appetite at all, making it so difficult for them to eat. And again, identifying the difference between ARFID and OCD again can help us to determine how we want to target treatment. Now, often folks with ARFID have had many repetitive, severely distressing experiences with food. They've attempted to eat food, maybe they're being forced to eat food as a young child, maybe they've had feeding conditions as an early child, and they've been forced so much that they maybe have actually vomited from having to eat food that they didn't want to eat. And now they have this inbuilt nervous system that associates certain foods with very stressful experiences. They may associate certain foods with throwing up, nausea, severe social anxiety about what people will say, and so forth. And this is another reason that we want to identify specifically what is going on, what is the experience of the person when they're having to eat a certain food or food group. Now, there's one additional form of ARFID that I want to make sure we cover here, and this is orthorexia. Orthorexia is a term that was coined in the early 90s. It is actually under the terminology and diagnosis of ARFID. But when we look at the function of the behavior for folks with orthorexia, they tend to be most concerned with the contamination of a food item. Often, when someone presents to us with orthorexia, they are saying that they've cut out foods because they want to eat as purely as they can. A lot of media has really sort of made this very fantasy of this idea of eating very pure, only real, whole, organic, whole grain, raw, vegan. That could be in any of these areas. And the person with orthorexia has become so afraid of food groups that they have minimized their diet. Some cases, 1 or 2 items that must be purely prepared, purely cooked, or no cooking at all. And they're not allowed to have any additional ingredients or pesticides or any additives. They have become so anxious about adding anything into their body and the fear of the consequences of that, but they too become incredibly malnourished and require mental health care. Again, orthorexia is understood under the condition and diagnosis of ARFID, but there are folks with orthorexia who feel that that term suits their symptoms better than ARFID in general. And that's why it's really important to present all of these to our clients and ask them which one of these conditions feels most relevant to you, which one fits you the most. When they can understand what's going on for them, they're more inclined to ask for help, to get the help they need, and to feel understood and recognized for the amount of distress that they're going through. Now, as you can imagine, it's probably likely that in many cases, but not all, it may be a combination of one or all of these conditions. A lot of folks with ARFID have coexisting OCD. A lot of folks with orthorexia have more general experience of ARFID. They may also have this sensory experience of food and this aversion to food because of ARFID symptoms and their underlying concern about these consequences of eating certain foods. A lot of folks with OCD also have disgust obsessions, and so we can actually see that the overlap here is going to be very high, just like it is with other eating disorders such as anorexia, such as bulimia, binge eating disorder. So before we move into treatments, let's just do a general recap. Folks with OCD are going to have a specific obsession and compulsion that are causing them to reduce or minimize in the food groups. For folks with ARFID, they're going to have more of a sensory aversion to food. It could be from childhood experiences. It could be something that they just experience in relation to that food that caused them a significant degree of distress. And again, they're going to be doing very similar safety behaviors and compulsions as folks with OCD, but the underlying fear or the underlying consequence is different. Now, for folks with orthorexia, again, very similarly, the actions around food and the aversion of food may look the same, but the fear is more related to the contamination and the fear of additives or any concerns with the purity of food. Now, when we talk about treatment, the good news here is that all three of these conditions can be treated with cognitive behavioral therapy. But the degree of the cognitive therapy, the behavioral therapy, and any supplemental treatments is going to be a little different. For folks with OCD, the gold standard treatment for OCD is exposure and response prevention. Now, this is a specific type of cognitive behavioral therapy where the person practices exposing themselves to their fear while they have response prevention, which is the reduction or elimination of their compulsive behaviors. That was what we're going to practice with OCD, and it has very good outcomes. When it comes to ARFID, we are still going to use cognitive behavioral therapy. And we may even use exposure and response prevention as well. The main thing for folks with ARFID is to remember that when they practice eating those things, it will reduce and lower the degree of anxiety and distress about it, but they may still have that disgust reaction. The cool thing about this is that we can still practice gradual exposure to the foods that they have been avoiding. And over time, they actually learn that they can tolerate the distress and the disgust and whatever aversion they experience. Similar to folks with OCD, we learn through exposure and response prevention that they can tolerate the uncertainty and distress and anxiety associated with their obsessions. The other thing that you want to consider when it comes to ARFID is there may be a need for occupational therapy, there may be a need for feeding therapy if needed, and we may also need to look at if they're children, are there any additional therapies that they may qualify for to help them move in the direction of getting back to the foods that they can eat and getting them nourished as fast as we can. Now, for folks with orthorexia, because it is somewhat a marriage between orthorexia and OCD, we're still going to be using exposure therapy. But the main thing here for all three conditions is as we move towards this model of exposure, we're going to be very compassionate in making sure that they feel empowered, that they feel in control of this process. We are not here as clinicians to push them to do something they don't want to do. First, in treatment, we are going to do a lot of psychoeducation. We are going to train them on why exposure is helpful, what other strategies such as mindfulness and dialectical behavioral therapy, a heavy emphasis on compassion-focused therapy, so that they're bought in on the process, that they feel empowered and they are leading the way. They're deciding what foods they start with, and we build a hierarchy from easiest to hardest so we can practice and take baby steps as we go. Now, the second stage of treatment is going to be treatment planning. This is where you're going to write down all the behaviors that you do and organize them in a way that feels in line with your values and feels doable for you. We're never going to do treatment where we take you from a 0 to 100. We want this to be a process where you feel supported and somewhat, even though this is an incredibly painful part of process, but somewhat excited about the idea of taking your life back from this condition. We may also do treatment planning about what rewards you're going to give you. How are we going to celebrate when you put this plan into action? The third piece is goal setting. What do you want? What do you want your life to look like? If you have this condition, how would you like it to be different? How would you like it to look if this condition wasn't taking over? Looking into that peephole and taking a look at the life you wish you had can help fuel and help us understand what we want treatment to look like. Now, as we mentioned with exposure therapy, we're going to be looking at this food-based exposure therapy. We are going to gradually, step by step, work you up a hierarchy where we practice being uncomfortable. We're not doing this to torment you. We're not doing this to punish you. We're doing this to help you build mastery over allowing discomfort to be there, learning that the discomfort is not dangerous, that nothing bad will happen. And if you do happen to feel the adverse experiences such as nausea, disgust, maybe even vomit, that you can tolerate it, especially if we do it in very, very baby steps. The beautiful part about this treatment is it helps the person with OCD, orthorexia, or ARFID learn to trust themselves with food, learn to trust their limits, learn to trust their body, and learn to trust their digestive tract in the way that it experiences and processes food. This takes time. I want to stress to you that this is not a throw it all in at once method. This is a deeply compassionate practice that's very much led by the person's values, whether it's their health and their wish to be able to eat in social settings, whether it's their mental wellness and freedom in that they don't want to be overwhelmed with preoccupation around food anymore. Every exposure we do is intentional, is compassionate, and values-led. We are never here to make our clients do something they don't want to do. We're never here to force them to do something that we wouldn't do ourselves or that they don't, again, want to do. Of course, they're going to need to stretch themselves a little. Of course, they're going to need to present with a good degree of willingness. But across the board, when I have practiced this with clients, they have all said that they finished treatment finally having some mastery over their food and their food rituals and routines, that they don't feel like this food aversion or this food anxiety or this obsession around food is running their life anymore. Now, the last part of treatment here is where we talk about response prevention and relapse prevention. Now, this is where once we've got them practicing eating those foods, we're going to focus on reducing any other safety behaviors or food rituals that they're using compulsively. So an example of this might be while they may be eating the food, we want to make sure that once they've eaten the food, they don't spit it out. Maybe they don't do a lot of rumination around it, a lot of reassurance seeking around it, that they're slowly and surely reducing those compulsive behaviors. Now, this tends to be more prevalent for folks with OCD, but again, they can go across the board. Another thing to remember here, if you're someone with ARFID, is a part of the treatment here is repetition. And that's going to be true for any of these conditions, but especially for folks with ARFID. Often when we're doing these food exposures, we're going to need a lot of repetition in order for them to gain that mastery. In some cases, people can get full desensitization or habituation with foods, but that is not an actual goal or outcome that we're goaling for with treatment. We're not looking for this to make eating completely easy, because that goal in and of itself can set the person up for a lot of frustration, a lot of hopelessness, and feeling like this just isn't working. Instead of the goal being an elimination of distress, we actually want to change the goal to the ability to tolerate any level of distress and have a really well-rounded tool belt to manage that distress if and when it shows up. So we will, as we go, be practicing a lot of mindfulness, compassion-focused skills. We're going to be practicing a lot of distress tolerance. We're going to be practicing a lot of value-based behaviors. So while you're eating and as you're having this distress, what can you engage in that is in line with your values? These things are going to help the person, again, build a sense of mastery as they move through these different treatment stages. Now, another important part of treatment is including the family. Often by the time that we get someone in our practice with these conditions, the family is frustrated, overwhelmed, exhausted. Maybe they're engaging in a lot of behaviors to help accommodate the person, and I completely understand that. This is a family condition. It affects everybody around them. And so in treatment, whether you have OCD, ARFID, or orthorexia, we're going to want to include the family as much as we can. We want to make sure the family has reduced any type of accommodating behavior that is not helpful to the person. We want to increase the amount of support that the family brings. We want the family to be encouraging them, cheering them on, sending them lots of love, and identifying how the family member can support them in a way that brings them more in line with their values and not letting these conditions run again, the show and the whole family system. This may involve a lot of psychoeducation with family members. It may involve family therapy if needed, and including the family and the loved ones in treatment as much as possible. And this is especially helpful for young children with ARFID and OCD. Now, as always, these treatments are going to be so helpful, especially if you're doing it from a place of compassion. Every time we can go through a treatment program and lace that compassion into every single stage, the kinder we can be, the more successful treatment will be, the more we can improve their outcomes, reduce procrastination, increase motivation. The benefits are unlimited. So please be gentle with yourself. If you are someone with ARFID, if you are someone with food-related obsessions or orthorexia, please be gentle with yourself. You did not ask for this. This does not mean there's anything wrong with you. This does not mean that you are going to feel this way forever and be stuck with this forever. I have had so many clients who have overcome these conditions with time and patience and support, and that involves you too. There are a few compassionate takeaways I want you to have after this episode. Number one, if foods feel scary, overwhelming, you're not alone. This is not your fault. This is not a fact that has to continue in your life. This is something you can overcome. Number two, the right diagnosis is key. It will allow you and your clinician to find specific treatment outcomes and strategies and modalities that will work specifically for your condition. So please, if you do not understand yet or you're still confused, reach out to a mental health provider in your area so that they can do a formal assessment. Number three, you deserve a life where you are not ruled by the fear of food, the shame of this condition, or the avoidance of food. You deserve to be nourished in your body, and you deserve to find some peace with the foods that you're eating, even if that is a smaller amount of food groups than other people in your family or out in society. We're all just doing the best we can. There's no perfect. We're not even going for that. We're just going on getting you back to a healthy lifestyle, nourishing your body, and breaking free from the mental anguish of these conditions. Now, if you have OCD, I thoroughly encourage you to reach out to the International OCD Foundation. You can, again, take an online course called Your OCD Toolkit. That's where I will show you the step-by-step tools and strategies and process that I take my clients through when I see them one-on-one. You can head over to cbtschool.com to get more information about Your OCD Toolkit. Now, if you have ARFID, I strongly encourage you to head over to Instagram or TikTok or YouTube and follow My ARFID Life. Hannah and her family show what it's like to have ARFID, and it is such a wonderful way of understanding ARFID and experiencing and seeing someone practice exposing themselves by eating their feared foods. Hannah is an absolute rock star, and I could not be more proud of the work she's doing and the advocacy that she has shown our community. So that is a great resource for you if you have ARFID and you're wanting to feel less alone. Now, with orthorexia, again, this is a condition. I encourage you to reach out to the OCD Foundation. You can go to my private practice if you're wanting specific treatment in this condition. We have licensed and unlicensed therapists who are so beautifully well-trained and absolutely inspired by the work that we do with clients with OCD and orthorexia, and we would love to help you. All you need to do is be living in the state of California. We would love nothing more to help. And with that being said, I hope this has given you a deeper understanding of the differences between OCD and ARFID and orthorexia and eating disorders in general. I hope that you feel more empowered. I hope that you feel like you have some direction now and you understand the nuanced differences between these conditions. The importance of this is it may be the difference between you having long-term recovery or not and getting your condition treated in a way that in which you deserve, which is a holistic, compassionate approach to your condition. Just have a wonderful day. As always, it's a beautiful day to do hard things, and I'll see you next week.